Listen-only mode.
Hi everyone and welcome to tonight's seminar. Tonight we're going to discuss saving teeth. So what I thought we would do is we would look at some of the alternatives to extractions. Obviously in most veterinary clinics one of the most common procedures we do is extractions. So I thought that rather than talk about that, what we'd talk about is alternatives. So what I thought we had in mind was to limit it to a few different topics. So in particular, we'll talk about tooth pathology limited to the crown. So this can involve tooth fractures, or it might involve hyperplasia, might involve a carious lesion, and we can split that into two or three categories. The first one being uncomplicated tooth fractures. So these involve just the enamel being exposed. So they're generally a light fracture or a smaller type trauma to the tooth surface. The next one can still involve what we call it uncomplicated crown fracture, but it would involve enamel and dentine exposure as well, but still no pulp exposure. The next category will be a complicated tooth fracture. So that involves the pulp being exposed. So if the pulp is exposed, by definition, the enamel and the dentine has to be exposed as well. And then we'll also look at things we can do in treatments for hyperplasia, so where the enamel hasn't formed properly, say for a young tooth that suffers either infection, inflammation, or some form of trauma, and the enamel doesn't form during the 8 to 13 week age when the enamel is normally forming in young animals. I've also put in a couple of other topics other than fractures if we have time. So the first one would be to discuss periodontally affected teeth. So when there's a deepened periodontal sulcus or a pocket formation, and look at antibiotic treatment and gel treatment in order to establish normal sulcus depths again and to eliminate the pocket formation. And we can also discuss and have a look at some gingival recession and how to close the dentinal tubules. And then also the last topic I'd like to cover tonight would be our linguoversion of mandibular canine teeth. So getting these animals in at a younger age than normal, and rather than thinking about amputating the crowns, talk about coronal extensions and have you think about how we can actually eliminate the linguoversion by getting the teeth to erupt into a normal position, or at least into a position where there isn't any trauma. So it may not necessarily be a scissor bite. So the first area we'll cover is uncomplicated crown fractures. So uncomplicated means that we don't have pulp exposure. And the first section of uncomplicated crown fractures I want to talk about is just fracture to the enamel and what we can do. So if we just lose some enamel and there's no dentine exposure, then there's really not any systemic complications. So it's just going to be a local effect. There's no dentine tubules exposed if there's still some enamel covering the dentine, so we don't need to worry about infection. We just need to worry about inflammation. So they're normally caused by trauma. In our clinic, we most commonly see them caused by chewing on fences or other sharp objects, sometimes getting hit by moving objects, such as golf balls or golf sticks or cricket bats, for example, in this part of the world. Baseball bats and maybe baseballs in the Northern Hemisphere. Um, Obviously, with some form of trauma, the pulp's going to be inflamed as well. So the treatment that we recommend is to remove the sharp enamel edges, because once the enamel fractures, you're going to have that matrix break and you're going to have sharp edges. As you can see in this diagram on the top, you've got a sharp enamel edge. We also want to restore the cosmetic appearance of the tooth, because a lot of clients don't like the fracture, and we also want to worry about pulpal inflammation. So we can see on the diagram, these diagrams come from the American Veterinary Dental College, which there's a series of them, which are quite welcome to use. It's avdc.org, and I think it's quite open to everyone, so you can use those on your client brochures or if you want to show a client a fracture. So we can see that the enamel is fractured and the dentine is not exposed, so therefore the pulp is not exposed. This is a clinical example of a dog that came in, and it has a fractured upper left third incisor, so tooth 203, using the modified Tridan system. The first thing we would do, you can see on the clinical example shown by the yellow arrow that the crown is fractured. It's lost some enamel. There's no dentine exposed. It's slightly discolored because it's a longer term fracture. We need to take a radiograph initially to ensure that there's no tooth root fractures, there's no endodontic complications, or it's not undergoing some form of pulpal death or necrosis, and there's no tooth resorption there. I would normally use a fluted burr, like in a high-speed handpiece or a Soflex disc, just to smooth the enamel, and then place the unfilled resin over the actual exposure. That's enough to cover the enamel edges. If you then want to make it cosmetically more pleasing, or if you want to make it more anatomically correct, then you can actually place a composite restoration to replace the enamel and therefore restore the normal anatomy. If the loss of the enamel is over, say, the enamel bulge, say on an upper fourth premolar tooth, then you may want to use a composite in that area because you want to restore the enamel bulge, and we'll talk about that in enamel and dentin fractures, because otherwise you're going to get food and debris being forced up into the periodontal space, and you'll end up with a periodontal lesion. It's also important before you place your composite restoration that you take the radiograph, as I said before, but also probe periodontally around the tooth just to make sure you haven't got a periodontal pocket, because there's no benefit in restoring or treating a damaged tooth that has periodontal disease or an endodontic problem that needs to be addressed as well. I like to put these patients on non-steroidals to decrease inflammation for approximately a week to 10 days if the trauma is recent, or if the trauma has been seen or observed by the owner, essentially to decrease the inflammation of the pulp, so you don't end up with pulpal necrosis and then a discolored tooth and possibly a periapical abscess or granuloma. The next degree of damage to a tooth could be both the dentine and the enamel is fractured rather than just the enamel. If the dentine is fractured as well and you lose dentine, then you're going to get exposure of the dentinal tubules, which by definition means that you're going to have access to the internal cavity or the pulp canal of the tooth. So you're going to get inflammation from the trauma of the tooth, and you're also possibly going to get infection. So if you have a trauma that's deep enough or intense enough to cause death of the odontoblast, you're going to have an open dentinal tubule, which then infection can travel down into the pulp and cause an infection in the pulp, and infection pulpitis, as well as just inflammation as well. So we need to treat, when this occurs, the immediate pulpal inflammation, decrease the inflammation so the pulp doesn't become necrotic and form a granuloma or abscess. We need to treat the tooth in order to prevent future bacterial invasion into the pulp, so we need to seal the dentinal tubules. A lot of clients also like the fact that we can cosmetically restore the tooth to its normal anatomical shape, and that's also important if it's a mandibular or a maxillary premolar tooth and you've got the enamel bulge. Not so important for canine teeth. In fact, often we won't, or I won't, restore a fractured canine tooth back to its normal anatomy, and I will deliberately make it shorter, because often you'll find that the forces, especially the stress forces that dogs will put on their teeth when they chew or bite into meat and shake toys, for example, actually shear off the composite. And of course, it's important to make the edges smooth so they don't cut the gum, sorry, cut the gum or the soft tissue as well. Another situation that we often see in clinical practice is enamel hypoplasia or enamel dysplasia, where the enamel hasn't formed properly. So you therefore either get immediate loss of the enamel and the tooth appears to be ring-barked when it erupts, so you don't actually have enamel formation, you still have dentine forming. You can also get brittle or soft enamel where the calcium phosphate matrix is actually more brittle, and if the dog chews on a hard object, then the enamel will chip off or break off, a bit like paint peeling off a wall. Very similar to that, and this is a good clinical example of enamel as it chips off. You can see in the upper picture where you've got loss of enamel on the buccal surface of 108 there, and you can see that the enamel is literally just peeled off or chipped off, a bit like paint coming off a wall as well. This will occur or be a cause due to infection or trauma during the typical 8 to 13 week phase when enamel is forming and the matrix is actually developing. So this is an important time for the animal not to suffer some form of systemic or local trauma or infection, because if the area increases in temperature, then the ameloblast, which forms the enamel, stops formation, and you have either weaker or irregular formation of enamel. By definition, if the enamel comes off, you're going to expose the dentine and therefore expose the tubules as well. So treatment is required in this particular case to seal the dentinal tubules, and we often see them in young puppies. So there's very little chance of the tooth actually becoming infected, and then we want to restore the enamel in this particular situation to restore that enamel bulge so you don't get food going into the sulcus. So in this case, we can see there's a white cord, which is called a gingival retraction cord. It's placed underneath the gum subgingivally, and that just pushes the gingiva up so you can actually get to the subgingival enamel. And then you can see in the lower clinical picture, there's a restoration being placed, and the tooth has been restored back to its normal anatomical shape again as well. And then once that's been performed, then the cord is taken out and the pet goes home, and the owner obviously needs to brush the teeth. So why is it important if a dog breaks its tooth and the dentine becomes exposed? And the main reason is because dentine is living, and we can see by the diagram on the left-hand side that the dentinal tubules provide a communication between the dento-enamel junction. So if we lose the enamel and the dentine becomes exposed, and that junction is exposed, and a direct communication into the pulp as well. And there's a large number of dentinal tubules. In fact, there's 40,000 per square millimetre. So any loss of enamel which exposes the dentinal tubules significantly increases the chances of bacteria accessing the pulp through these tubules. And obviously then you end up with pulpitis, infection within the pulp canal, and then a high chance of periapical granuloma or an abscess as well. Treatment involves three main areas. Again, the most important factor is to try and decrease the inflammation using a non-steroidal to limit pulp inflammation, because if the pulp becomes inflamed, it swells up, cuts off its own blood supply, oxygenation, and then becomes necrotic, and then there's a high chance of getting a granuloma or an abscess. The second one is sealing the dentinal tubules, as we said before, because we want to prevent the bacteria accessing the pulp canal. And we do this by placing an unfilled resin followed by a composite or a glass ionomer restorative. We can see in the clinical picture on the right-hand side how both the enamel and the dentine has been fractured on this upper fourth premolar 108. And if we were to take that piece of tooth away, that buccal, what we often call a slab fracture in clinical practice, we would have quite an access into the periodontal space and into the periodontal ligament as well. So it's important that we place a composite and restorative there to build the tooth back into its normal anatomical shape, or the bulge, I guess, is the main thing we're trying to place back. Cosmetically, clients like the teeth to look normal as well. There's also less chance that you'll get periodontal disease if you have a normal shaped tooth, because of the chewing mechanism, and you have natural flow of meat and plaque and cleaning of the teeth as well. So cosmetic appearance is important, not only for appearance but also to prevent periodontal disease. We often I'm often asked in workshops especially, what do we do with teeth that have abrasion or attrition? Attrition is a bit different because attrition involves the teeth within the mouth rubbing against one another. So generally speaking, you can't do a lot to teeth that have attrition, because if you were to make them larger or build them up or make them back into their normal anatomical shape, then the tooth that's causing the trauma will just continue to do that. But abrasion is a different matter. So here we have a German Shepherd dog that has abrasion on the third incisor and the canine teeth on the distal surface of both of those teeth. It was a cage chewer. And you can see it's worn away the enamel and also the dentine on the left-hand side, or the distal aspect of both of those teeth. Often with abrasion, because of the vibrations that are traveling through the enamel and the dentine, we often find that odontoblasts are stimulated and we get tertiary dentine being produced. So often the tubules are actually sealed as a protective mechanism because of the abrasion. But this is not always the case. You do find that the dentine that's produced is very disorganized, it's very sclerotic, so it often doesn't have a tubule in it, but that's not to say that it may not still be able to allow access of bacteria through the dentine into the pulp canal. I think the most important factor before we do any dental work is talk to the owner, consult with the dog, and also talk to a behaviorist. So we need to work out what is actually causing the problem. So a behaviorist would actually help us here. So this particular dog had separation anxiety. It was treated with behavioral modification and medications, and I think also having something there at home, either making a noise or somebody with the dog, also made a difference as well. So therefore the dog stopped chewing the cage and also the fence and the back door. So the next part of the treatment that we want to do as veterinary dentists is to take a radiograph of the tooth to firstly work out how far away the pulp is from the actual dentine. If it's very close, you may not be able to move any dentine which is diseased, in case you want to make like a cavity preparation. We also want to take a radiograph to rule out any periodontal pockets. You need and you also use a periodontal probe to make sure you've got normal periodontal health, so you haven't lost any alveolar bone, you don't have a periodontal pocket. We also want to rule out any endodontic disease, so subgingival pathology like osteomyelitis, as well as abscesses and granulomas. So if we have a structurally sound tooth, then we can then go ahead and restore it. So in this situation, we elected to restore the tooth just in a composite resin. So that involves cleaning the teeth, scaling and polishing the teeth. So you scale the teeth as you would normally scale the tooth. You then need to pumice or clean the teeth. So you polish the tooth with a pumice. You shouldn't really use normal polishing paste because it has glycerine in the mixture. Also additives that have glycerine in them, for example, shouldn't be used when you're using the water from your high speed or in your polishing paste as well, because the glycerine will stop the actual filling material from bonding to the tooth surface. You then etch the tooth with phosphoric acid, 37% phosphoric acid, to clean the tooth and open up the enamel matrix. Then a composite bonding material, an unfilled resin, and then a composite restorative are placed onto the tooth, as you can see here, to build up the tooth back to its normal anatomy, and also cosmetically it looks quite good as well. We can see on the tip of the canine tooth there's a small dark area there, and that's just normal wear. So that's a discoloration of the dentine from normal wear. Then once the composite material has been placed, the tooth can then be polished, either polished with a paste or polished and smoothed off with like Softlex discs, for example. So that leads us from uncomplicated crown fractures, where we just have enamel and dentine exposure, to more advanced fractures of the teeth where the pulp is actually exposed. So when the pulp becomes exposed, what we find is they come under the classification of what's called a complicated crown fracture. So this is a complicated crown fracture is one where the pulp is exposed. Now it could be immediate, as in just a recent fracture, such as being hit by a moving object like a car or a cricket bat or something along those lines. Or it could be a long-standing fracture that the person, like the owner or the vet, finds during a routine clinical examination, like a vaccination or skin infection or some other reason the person's brought the dog in to the clinic and the veterinarian has examined the mouth and noticed that the tooth is fractured. If the tooth is immediately fractured, then we get an immediate inflammation of the pulp because the pulp is sheared off, and immediately the pulp becomes infected because bacteria, oral bacteria, immediately invade the pulp tissue as well. So treatment is directly related to an endodontic procedure, and it's directly related to the time between the time that the tooth is fractured and the time you actually get to the tooth. So here's an example, clinical example of a mandibular canine tooth. In fact, this would be the lower left canine 304 with a large pulp, and you can see the red pulp bulging out through the canal. It's recently been fractured. If it's been fractured less than 48 hours, then the chances of success are much higher than treatments that are done 48 hours after, or even a week or 3 weeks or 2 years after the pulp has been exposed. I published a paper and we did some retrospective research which looked at pulp capping success at different time intervals, which I published in 2001 in the Journal of Veterinary Dentistry. And what I did was I retrospectively looked at all of the direct pulp cap procedures that I'd done in dogs that we knew the pulp exposure time to treatment time. So dogs that have, say, broken its tooth today on a lawnmower or on a cricket bat, and then I managed to get them in, or the owner brought them in tomorrow, for example, so that's less than 48 hours, or they brought them in on next Monday, and today might be Tuesday, so therefore, less than a week. And then also those that were done within 3 weeks as well. So we split them up into those 3 cohorts. And any animal that was treated more than 3 weeks after pulp exposure, we traditionally did a root canal on back then. So this is nearly 15 years ago, probably longer, 15 to 18 years ago. So what I did was I looked at each of these animals and I got them back into the clinic, and we looked at their post-operative radiographs. So we did radiographs traditionally at 3 months and 12 months after the procedure, which was our standard. And I then also, as part of the study, brought them back after 36 months as well, so 3 years afterwards. And there was 97 teeth in 76 dogs, so a reasonable number. And what I found was, and what the results showed, that treatment success significantly decreased the longer the time interval between the time of fracture and the time of treatment. So for this study, I broke them up into less than 48 hours because we didn't really have many that actually got brought in on the day, as in if it happened this morning, they didn't come in this afternoon. So we found that the next day was the most common treatment time. So we broke them up into less than 48 hours, which was like on the day or the next day. We then chose a time frame of 7 days, and then after 3 weeks as well. And we found that treatment success literally halved every time the time went from 48 to 7 days to 3 weeks. So if you could treat the tooth within the first 48 hours, then your treatment success, we found, was 88%. So treatment success was at 36 months, so 3 years after the actual procedure. The pulp canal was narrower and consistent with its contralateral tooth, proving or showing that the tooth was still vital. So in other words, if the tooth was still continuing to produce dentine, as you would expect it to in a normal vital tooth, then the pulp canal would narrow. So therefore we assumed that was the case on a vital tooth. If you drew out the time interval between fracture and treatment to 7 days, then the treatment success just was over half of what it was if you did it within 48 hours. So it dropped from 88% to 41%. And then if you drew out the time again to 3 weeks, then the treatment success halved again and dropped to about 23.5%. So from 88 to 41 to 23. So thus the secret to success if you're going to do pulp capping in fractured teeth is to get them in early. The way you do this, and the goal is to reduce the inflammation. So once again, non-steroidals to reduce the inflammation in the pulp canal, and also to remove the infected coronal pulp tissues. So we don't know at what rate the infection travels down into the pulp, but it's assumed that it would have to be at least 1 millimeter or 2 immediately, because you're going to get a surface bacteria a surface layer of bacteria as soon as the tooth is fractured, and then it's obviously going to penetrate into the pulp tissue. So one advantage in doing this particular procedure is that you will have to remove at least 4 millimeters of pulp tissue in order to put your medications into the tooth. So I think also part of the success of doing this procedure within the 48 hours is that the actual bacteria haven't penetrated more than 4 millimeters. So by removing that piece of pulp, you're also removing any infection, and then by putting the animal onto an anti-inflammatory, you will then decrease the inflammation as well. So our goal is to reduce and remove the infected coronal pulp, but also one of the major goals in direct pulp capping is to produce a dentine bridge. So a bridge that actually forms across the top of the pulp that we can artificially make by placing a material that stimulates the odontoblast to produce dentine. And what we find is the most successful materials to date have been the calcium hydroxide based materials. And there have been newer products that have been brought onto the market. MTA is one, Biodentine is another, but I'm just telling you about calcium hydroxide in this seminar because it's been around for such a long period of time. It's easy to work with and it's very cheap to purchase as well. So after you take the radiograph to confirm that you haven't got any other fractures, so there's no point doing the procedure if you have numerous root fractures, for example. So on the bottom of this slide, we can see three radiographs on the left-hand side, and in the middle are radiographs immediately after fracture. So we can see the crown and part of the root on the left-hand side, and it has a normal periodontal space. It has no periodontal probing depths. It has a relatively thin pulp canal. So the pulp canal is thinner or narrower than the width of the pulp. So it's a middle-aged dog. We then have the root in the middle, and we can see the periodontal ligament, which is the thin black radiolucent line hugging the tooth going all the way around the apex. So there's no periapical lucency to speak of, because you can see the ligament travels all the way around the apex. And then once we've taken that, we can determine that the tooth is healthy and it's not mobile, it doesn't have any periodontal or endodontic issues. We can then say, okay, well, let's do the direct pulp capping procedure. So we take out a sterile round burr and remove our 4 millimeters of pulp. We then obtain hemostasis. Then we place the calcium hydroxide directly onto the pulp stump, which has got a blood clot in it. And over time, and time is generally around 90 days, the calcium hydroxide is going to stimulate the odontoblast to produce a dentine bridge. So on the right-hand side, we can see that the tooth has a white, dense, radio opaque area on top of the tooth. So this is directly after treatment, and we can see that the treatment has been successfully placed there. So over the calcium hydroxide material, we then place a glass ionomer filling. Glass ionomer filling is used to produce a hermetic seal, because you don't want bacteria traveling down into the calcium hydroxide or down into the pulp. And then on top of the glass ionomer, so the glass ionomer is about 1 millimeter thick. The calcium hydroxide is about 1 millimeter in thickness as well. So we've now used up 2 millimeters of our 4 millimeter void. And then we place on top of that a 2mm layer of a composite restoration, and that restores the tooth back ideally to its anatomical sort of position, anatomical shape, if you can. It also adds some strength to the tooth because you've got some composite inside the tooth. But if you really want strength and you really want a proper cosmetic appearance, as I've written here, you would need to place a crown on top of the tooth in the long term. So there's a diagram on the top of the picture there, and we can see that there's a large area of pulp, which is taking up the vast majority of the tooth, maybe about 60 or 70%. And then on top of the pulp on the diagram is the calcium hydroxide layer. And then on top of that is the GIF, the glass ionomer filling layer. And then on top of that is the composite on the composite layer. So that's a sort of a diagrammatic view of what you would expect to see if you were to take a radiograph. The calcium hydroxide you're not going to see on radiograph until the bridge is formed, but the glass ionomer and the composite is radio opaque, so you should be able to see that, and you can see that in the radiograph on the right-hand side. It's a good idea to radiograph these teeth 90 days after you've done the procedure, because it takes about that long for the dentine bridge to form, and then you'll see whether you've had treatment success. If you have and you've got a dentine bridge and the composite is still in place, then there's no reason to do anything else except just monitor the tooth on an annual basis. If you are not able to do a direct pulp capping procedure for whatever reason, the tooth is endodontically compromised, for example, has an abscess, the fracture is greater than 48 hours, then the next thing you would need to consider, rather than take the tooth out and extract it, would be what's called a root canal procedure. And a root canal involves taking out the entire pulp material and then using the removal of the pulp and the decrease in inflammation and infection to allow the body to heal any abscess or osteomyelitis that is present there. So the pulp's removed and the canal and dentine walls are then debrided using endodontic files. We can see this on the top picture. There's endodontic files transversing the crown and into the roots of the upper fourth premolar. The canal is sterilized using 4 to 6% hypochlorite flush. We normally flush that between files. And then the canal, once it's cleaned and dried, is obturated with a material called gutta perca, and normally a sealer such as a calcium hydroxide or one of the resin-based sealers. And then the tooth is closed with a restorative material such as a composite. So the bottom radiograph is of a tree kangaroo that had fractured both of its mandibular incisors, and the really dense white material within the tooth is the gutta perca material and the sealer, and this gutta perca comes in long cones, and you can see that they extend past the edge of the radiograph. So that covers the section that I wanted to talk about with regards to fractures, uncomplicated and complicated crown fractures, and what you may be able to do in practice using composites and bonding agents. The next section I want to just discuss is periodontal disease. We've covered periodontal disease in various parts and little fragments in other webinars, but essentially periodontal disease is, as you realize and know, is a bacterial-driven disease. It's caused by plaque, which is a mixture of saliva and bacteria, and then the bacteria stimulate the host's immune response, so we then get loss of the attachment, so loss of the periodontal ligament, loss of the cementum, loss of the alveolar bone, and one of two things occur. Either we get an increase in periodontal sulcus probing depth, or we get a pocket formation, or we get gingival recession. So both of these situations can be treated, and without extracting the tooth, hopefully restore the normal, at least partially restore or rejuvenate or regenerate normal periodontal tissues. So the top clinical picture is showing us a cat, lower right canine tooth, periodontal probe measuring about 7 millimeters in depth on the mesial surface, and then the lower clinical picture is showing us a dog with a maxillary left canine tooth, and it looks like there's about a 2 or 3 millimeter loss of gingiva there, so gingival recession. So if we have a periodontal pocket forming, as you'd be aware, a periodontal probe can be used to determine this, and a periodontal pocket infers that we actually have loss of the attachment of the tooth. So we have loss of the periodontal tissues such as the cementum on the tooth surface, the alveolar bone, surrounding the tooth, and the periodontal ligament as well. Measurements using the probe are taken in millimeters around the tooth. These measurements are then placed onto a dental chart. The dental chart allows us to record the readings at the time. They're also important because when we go back, if we're going to do some form of periodontal therapy, we can then go back and review the chart that we did 3 months or 6 months ago and actually compare the periodontal pocket depths that we record at a later date to the current levels and see whether there's a difference. So if your periodontal therapy is working, then there should be a decrease in periodontal probing depth. So this is the importance of a dental chart. The other reason you may want to consider doing a dental chart is for litigation reasons. If for some reason you do extract a tooth or you do some form of periodontal work and you're recording your pathologies on the chart, if you happen to end up at the vet surgeon's board or in court, then you've always got your dental chart to back you up as well. So the measurements are taken. Periodontal pocket is considered to be there and present if the probing depth is greater than 3 millimeters in a dog and more than 1 millimeter in a cat. The most common, apart from just your normal periodontal pockets that you find in most teeth, the most common areas that I find in practice is on the palatal surface of maxillary canine teeth, and they're also quite responsive to treatment, but any teeth obviously can be affected by a periodontal pocket. We use a curette such as the one on the right hand side here, which has a blade on the last 2 to 3 millimeters, followed by the shank and the handle. The blade should be sharp, so it needs to be sharpened on a regular basis, ideally after each use. It's then placed subgingivally, as we can see in the clinical picture on the bottom of the slide, against the tooth surface to the depth of the periodontal pocket, and then used with downward pressure and scraped across the tooth to remove all the endotoxins and the bacteria, the dead cementum, the necrotic material, any food or bacteria that's in the pocket. So you should end up with a nice glassy surface on the tooth, which could be dentine or it could be cementum. And you should also be debriding the internal surface of the periodontal pocket, so you end up with nice clean epithelial tissue as well. So the aim then is to stimulate this clean epithelial tissue that is full of fibroblasts in order to reattach to the tooth surface. Now, if you do nothing and you just leave it and the dog goes home and eats, then it's a high chance that the area will just fill up with food and debris, bacteria. So we can use a product in the periodontal pocket, which is a gel, and we can impregnate that with antibiotics. Ideally, doxycycline works the best because it has both an antibacterial action as well as an anti-collagenase effect. So it actually binds to collagenase, which is one of the enzymes that are produced by macrophages and bacteria to break down the surrounding collagen in the periodontal ligament. It also stimulates fibroblasts, so we get fibrin being produced, and we'll get reattachment of the epithelium onto the wall of the tooth, onto the cementum. So in the United States, this product is available as Doxyrobe. It used to be available worldwide as Doxyrobe, but it now is only available in the US. In other countries, such as Australia and New Zealand, you can get it from a compounding pharmacy. In Australia, I get ours from a company called Compoundia, which are in the Docklands in Melbourne. And it took us probably about 18 months to get the mixture correct, but there are other compounding pharmacies that can do can do this for you. This is what's called a local antibiotic delivery system, and it comes in 2 syringes. It comes with the doxycycline in 1 syringe, and it comes with the gel, the Pluronic gel, in the other syringe. You mix them together. And the interesting fact about this particular gel is it's very temperature sensitive. So in the fridge, it's a liquid, so when it's cold, you can actually squirt it out through the syringe, and you attach a cannula to it so you can inject it into the periodontal pocket. And as the body obviously warms it up, it becomes a solid. So it sits, as you can see in the bottom right-hand side in the diagram, the yellow gel is sitting within the periodontal pocket, sitting against the epithelial lining of the wall and against the cementum of the tooth. And over time, the gel breaks down. So as it degrades and the mass becomes smaller, it releases the doxycycline. It also, by definition, as it gets smaller, it moves the epithelial wall closer to the tooth as well. So then you can get a bond of the epithelium back onto the tooth. So it rejuvenates the normal anatomy, and it reattaches the gum back onto the tooth. So we find that we check the animals after 2 weeks and 4 weeks, 6 weeks, 8 weeks, etc. And we find generally after about 6 to 8 weeks, we normally have normal periodontal probing depths again, so normal sulcus depths if we use it in a pocket. The only downside, or I should say there's a few downsides. One downside is that it's technically difficult to use initially, and what you need to do is you need to make sure that the actual cannula is to the depth of the pocket, so you backfill it rather than trying to squirt it into the pocket. That's one trick. It's best not to overfill the pocket, because if the dog goes home and chews on something and it catches a tag of the gel, it tends to pull the gel out as well. One advantage of this is that it's quite painless. So if we find after 2 or 4 weeks that the gel has been lost because the owner inadvertently cleaned the teeth, for example, and removed it with the toothbrush, or they ate, the dental food and they pulled it out, then it's possible for one of the nurses or techs to just make up a new syringe and actually inject it into the periodontal pocket as well. One advantage of it is it lasts for, once you make it up, it lasts for around 14 days. Before it's made up, the Pluronic gel lasts forever. It has no expiry date, but the doxycycline, I believe, has about an 18-month expiry, so it lasts a long time before you purchase it. I find in the clinic, the more syringes you purchase, the cheaper they become as well. So rather than buying one, you're probably better off, buying 10 or 20. The other possibility when you get a plaque infection on the tooth surface, rather than getting a periodontal pocket, is you could get gingival recession. So if you have gingival recession, what you find is that the cementum on the tooth root is exposed, and therefore the dentinal tubules may be exposed as well if you get some wear of the cementum and then the dentine being exposed. So it's important from a pain point of view that you seal the dentinal tubules, but it's also important that you seal them so you don't get infection into your tooth. Many of you listening may have a habit where you take your toothbrush, you put your paste on the brush, and if you're right-handed, you probably clean your maxillary left-hand premolars and canine teeth first. And if you're left-handed, you're probably going to do the opposite. You're going to clean the right-hand canine and premolars as well. So what dentists often find in people is you get gingival recession on the maxillary premolars on the opposite side to the hand you used to write with, because you immediately brush the heck out of your gum and you've got all this abrasive paste on it. So, for the budding youngster who's about to clean their teeth, it might be worth swapping sides when you start brushing. Brush your left one day and brush your right the next day when you start off with your toothpaste on your brush. So now we've got our gingival recession and our tooth is exposed. What we can do is we can clean the teeth. That then obviously cleans any plaque or bacteria off the tooth surface and any calculus as well. But it will then unfortunately expose the dentinal tubules, which need to be sealed. So you can use your curette to clean the tooth. You then lightly etch the tooth 15 seconds with a phosphoric acid, and then you could just place an unfilled resin directly on, like a composite resin, directly over the exposed dentinal tubules. This will last, anywhere up to 6 months on a normal dog. And then you would need to obviously get the owners to brush the area in order to maintain gingival health and not end up with a periodontal pocket. So what we can see in these clinical pictures is gingival recession, the same dog as before. So this is the dog that has gingival recession. We can see it's 3 millimeters in depth based on the probe there. The tooth's then been cleaned with a curette, it's been acid etched and then washed and dried, and using the green microbrush we're placing an unfilled resin, which is like a thick claggy glue on the tooth surface. Then it penetrates into the dentinal tubules, attaches to the collagen fibrils there, or fibrils there, and then the bottom picture is me shining a blue light. So the resin is actually light cured, what's called light cured. In other words, it sets when you shine a blue light on it. It takes about 10 seconds to actually cure, and then any rough edges are then just gently removed with the curette. This is like a technique that can easily be used in nearly any practice. Lastly, I'd just like to touch on malocclusions. And the reason I think I want to talk about this is because we get a significant number of referrals of animals that I guess I see too late, and the permanent teeth have erupted into an abnormal position, linguoversion of the mandibular canines, and they're penetrating the hard palate. And they're brought to me, or they're referred to me, in order to either crown amputate or extract or orthodontically move the teeth. Now, sometimes you can't orthodontically move the teeth because there's no diastema between the canine and the third incisor. Sometimes it's a young dog and they're boisterous and they want to chew on a lot of hard objects like Labradors, for example, blue heelers. So we don't really want to crown amputate them and pulp cap them because they're just going to keep fracturing the tooth off. So we end up extracting some of these teeth. So I thought it might be worthwhile just pointing out that if you do happen to see these malocclusions in young puppies, that there's a couple of things that you could do in practice before you get into the point where you have to think about what you're going to do with the fully erupted canine tooth. So invariably you'll see these at 6 weeks of age, or sometimes at 12 weeks of age when the animal comes in to be vaccinated. We'll call them base narrow or lingually displaced deciduous canine tooth, or linguoversion of the canine teeth. It's the mandibular teeth that are causing the problem. They may be too narrow, so they're penetrating the hard palate. They may be causing ulcerations. The worst cases we've seen are oronasal fistulas. At this point, when the tooth appears to be either vertical, or even if it is slightly obliquely angled but it's penetrating the hard palate, I would recommend you extract the deciduous teeth immediately, rather than waiting to see what happens. So these are two examples. Well, this is really one example with two pictures, a left-hand side and a right-hand side. And what we can see is that the lower canine, the mandibular canine tooth, is actually positioned caudal to the maxillary canine. So in an abnormal position, because the mandibular canine should be positioned cranial or rostral to the maxillary canine. So these teeth would be extracted with the purpose that we then want to be able to do a procedure, if necessary, on the adult canine tooth without either a retained or a persistent deciduous tooth. So then we've got two teeth in the position, then we have to extract the deciduous tooth and then worry about how we're going to move the permanent tooth laterally. I would prefer to extract the deciduous tooth now and then worry about what's going to happen with the permanent tooth later. So we've extracted the deciduous tooth and we're now going to observe and treat the mandibular canine when it initially erupts. So after I've extracted the tooth and I'm sending the pet home, we'll say to the owner, you need to watch this tooth from about 20 weeks, or watch this animal from about 20 weeks of age, and every day I want you to check, and I want to know and I want you to return when the mandibular canine tooth is 5 millimeters through the gingiva. So once it erupts, and it's now 5 millimeters as a minimum through the gingiva, we can then have a look at the canine tooth and work out and estimate, I guess, which direction it's traveling. So if it's erupting and it's going to travel directly into the roof of the mouth, or it's going to travel into the permanent canine or into some other structure, then it's possible and highly recommended at this age to increase the height of the mandibular canine tooth and direct it into a position where you would like it. So this is really treatment of malocclusions, and I'll call it incompletely erupted canine teeth or mandibular canine teeth, because the best time to actually treat these is when the tooth's 5 millimeters through the gum. The aim is to guide the tooth or guide the eruption pattern of the canine into a position where it's not causing trauma. So it may be into the diastema. In this particular dog, you can see that because it's got a class 2 malocclusion where the maxilla is much longer or the mandible is much shorter than its opposition, there is no way you're going to be able to get that mandibular canine tooth so it's rostral to the maxillary canine. So the aim was to direct it caudally and laterally. So you can see on both these pictures, the top one is the right-hand side, the bottom one is the left-hand side, and you can probably appreciate it more on the bottom picture, how the composite material, which is the restorative material, and it's added to the tip of the canine tooth. You can see how it's angled laterally. See how the tooth is positioned, and then the composite material almost bends at about 30 degrees laterally. So then as the canine tooth erupts, the composite material is going to guide it into the position that we actually want it to finally rest. So on the top two pictures, they're just a representation again of the previous two. So these two here, left and right tooth. So this is the dog at about 22, 23 weeks of age. The teeth have just erupted. They're about 5 or 6 millimeters through the gum. The top teeth then are you can see are in that position, and then as the tooth erupts, it's actually going to be forced into a position caudal to the maxillary canines. So this normally takes about a month. So give the owners an idea that this is going to take about 4 weeks for the teeth to erupt into a normal position. And we can see on the lower pictures here now that the canine teeth are in a position where they're not causing trauma. So they're actually sitting nicely behind the maxillary canine teeth. So rather than saying, oh, we'll extract the teeth, or the other options are a crown amputation or orthodontic movement, this is quite an easy procedure to do in practice if you get the tooth in early enough. So in other words, at around 5 millimeters through the gingiva. So tonight, what I've aimed to do is to give you some guidance and some ideas on some of the procedures which you could do other than extracting teeth with trauma or periodontal disease or even malocclusions. And we discussed what to do with teeth that have just enamel fractures, smooth off the enamel, restore them. Those that have enamel and dentine fractures, so once again smooth the enamel, try and remove and reduce the amount of inflammation that the pulp is suffering as well, and also restoring the tooth and sealing the dentinal tubules. And then I think the take-home message with fractured teeth with pulp exposures is that the options are either direct pulp capping or root canal. Like extracting the teeth is one option, but it's not preferable, and leaving the tooth and allowing the pulp to become infected is certainly not an option. But if you're going to do direct pulp capping, you need to get in there fast. So generally the thoughts are within 48 hours. There's other options for periodontal disease with a periodontal pocket. It is possible to use paraceuticals such as the doxycycline impregnated gels, and also if you have gingival recession, it's also ideal to think about sealing the dentinal tubules. And if you see any young puppies out there, then you may want to consider the ones with the malocclusions adding height or a coronal extension to the tooth, and then think about moving the teeth into a non-traumatic area. So this is the last webinar for this series and for this year. My plan is to continue these, and we've had very good feedback from quite a number of veterinarians now. We've had excellent attendances as well. My aim is to continue these throughout the next year, 2016 as well. We'll probably repeat some of these for those that weren't able to get online and ask a question at the time. And we'll also look into some other topics. And also I was thinking of what I might do is actually look at individual procedures and maybe have like a webinar on like a particular procedure as well. So I'm always open to, what everyone would like to know. But once again, our website www.vdec.com.au will continue to have the practical tips on it as well, and also a forum to discuss cases. I'm always free to be emailed with cases if you want to contact me. Otherwise, we just wish everyone a good night, and thank you very much for your attendance.